So hey guys, my name's Nish. I'm one of the emergency medicine trainees at MRI. I'm also doing a master's in medical ultrasound at the moment. So this talk's going to be about point of care ultrasound. So I'll talk a little bit about the past, present, and future of POCUS. I'll give you a bit of an overview of POCUS in emergency medicine, so courses, accreditation pathways, etc. And we'll dive into some of the evidence base and share a few tips on how to train on the shop floor. And then we'll finish with a few cases. So I don't expect anyone to know who this is, but this man was a French physician who was the inventor of the stethoscope in 1816. It wasn't until 1851 when the first stethoscopes were actually commercially produced and used. But despite that, there were still a lot of skeptics out there, including L.A. Connor, who was a cardiologist and founder of the American Heart Association, and supposedly still carried a silk handkerchief to place on the chest during auscultation. And 60 years later, a professor of medicine in 1885 famously uttered this phrase. So stethoscopes haven't had the easiest of times being adopted into medical practice. And I think ultrasound and a lot of new technologies and new ideas go through a similar phase where you've got the early innovators on this side over here and the early adopters. And then you've got sort of the majority of people in this area here, which take a little bit more convincing before they can adopt these new ideas or technologies. And in between that, you've got the chasm where a lot of these ideas fall into, if due to lack of interest or lack of evidence, or for a number of reasons. And at the end here, you've got the laggards, which are essentially the dinosaurs who, it doesn't matter how much convincing, how much of a convincing argument you make, but they're just never gonna change their minds. But hopefully through this, if I can convince at least a few of you that ultrasound is the way forward, then I would have done my job. So a bit of a history lesson in POCUS then. So in the early 90s, POCUS was introduced fairly early on into the EM curriculum in the US. It took a little bit longer to get introduced in the UK. So in 2002, NICE mandated the use of ultrasound for central lines. It was only until 2009 that POCUS was introduced on the EM curriculum over here. And since then, other specialties have adopted POCUS as well, such as the Intensive Care Society and the Acute Medicine Society, and they've established their own subcommittees and courses. And there have been a few sort of landmark papers in between that have sort of shaped the evidence and our ideas around POCUS. So with regards to ultrasound in emergency medicine, there's essentially core emergency medicine ultrasound, which was formerly called level 1. That's the one that most of you will probably be familiar with. So there are 4 components in that. There's the fast and extended fast, AAA, vascular access, and echo and life support. For those wishing to pursue more advanced ultrasound skills, there's the enhanced emergency medicine ultrasound, or level 2, which includes things like biliary, renal, lung ultrasound, shock and echo, and a few others. So for level 1, the certification pathway essentially starts with you doing the RChem learning e-modules. I think there are about 6 of them on the website. You then attend a level 1 course, and then log at least 40 scans, so about 10 in each of the components, and 10 reflections on any 10 of the scans, but it needs to be a decent spread. You then do 4 triggered assessments, so 1 for each component, and then you've got your final sign-off at the end, which at the moment I believe is still done either via a finishing school or through your regional ultrasound lead. That's all probably going to change in the next year, because I think we're trying to move towards having local sign-off, just because trainees have been finding it increasingly more difficult to get their final sign-off. And there's enhanced or level 2 ultrasound, which sadly in practice doesn't really exist. And the accreditation pathway is very poorly defined. So at the moment, it seems that the most straightforward way to, if you're interested in getting more advanced ultrasound skills, is actually doing a postgraduate degree or a master's level degree. There are other courses available. So the Intensive Care Society have FUSIC, which they've now combined FICE and QSIC into one. And they've slightly changed the structure of it. So it's a more modular structure where you can accredit in each individual module separately. Similarly, the Acute Medicine Society have the FAMOUS course, which consists of DVT, lung, renal, and vascular access. So there's no echo in the FAMOUS course. There's the FEEL course, which is focused echo in emergency life support. So that's the Resus Council endorsed course. So that's sort of focusing on echo in the peri-arrest or arrested patient. And then obviously there's the BSc accreditation, which is the full echo course, which the cardiologists do. So as I said earlier, sadly, there isn't a committee for POCUS in emergency medicine at the moment for a variety of reasons, mostly political. But we're currently in the process, me and a bunch of other people are in the process of setting up a committee called FEMIS, which hopefully will bring together core and advanced POCUS applications and sort of bridge the gap between doing sort of level 1 and doing something like a master's level degree. And we're hoping to set it up similar to FUSIC in that it would be a modular training structure. And there would be the possibility of virtual mentoring as well, which seems to be the future of where ultrasound training is heading. So by that, I mean that you'll be able to upload your scans and get mentors to review them remotely after maybe just a few direct supervised scans. And we're hoping to get accreditation or at least endorsement by BMIS as well. So a few sort of training tips for the shop floor. So for those of you who are have done a level 1 course, or you're starting out, you're getting your logbook together, I would try and identify someone in your department or in your region that can mentor you. Try and aim for at least doing 1 scan a shift. I think in the current climate, we can probably afford to do a lot more. And this is probably a good time to start training and start building up your logbook. Do save all your clips and all your images and try and review them regularly with your mentors. And there are loads of apps out there like Echolog and SonoClipShare. SonoClipShare is free at the moment. So you can upload your anonymized scans to SonoClipShare and use that both as a logbook and send them to your mentors for remote review as well. And you can get feedback and you can comment under each scan if you want. So I would personally aim to, if you're interested, to try and get at least your core level 1 sign off done by ST3 or 4, because that means you're not scrambling around at the end trying to get your logbook together. And for those who haven't done their ICU or are due to do their ICU placement, that's a perfect time to actually get your echo logbook up to scratch, because you won't get as much time to sort of practice echo as much in the ED as you do in ICU. And there are loads of FOAMed resources out there. So there's 5-Minute Sono, the ultrasound, Core Ultrasound, POCUS Atlas. POCUS UK is a fairly new website that me and a few other people have recently set up. So it's still under construction at the moment, but there's a few resources up there. And we've got an image library up as well. So those wishing to pursue more sort of master's level education, there are a few courses out there. So I'm currently doing the master's at Teesside University. I do know that King's College do a point of care ultrasound master's as well, but I don't know too much about that. The one at Teesside is a part-time course, so it's meant to be done. It's meant to be for people working. A lot of people work full-time and do the master's on the side. I'm self-funding it at the moment, but I do know there's in some other regions there are POCUS fellowship posts where they're funding at least the first year of the master's. So if anyone's sort of moving deaneries or anything, I know that Leeds offer a POCUS fellowship, and so do Newcastle and a lot of places in London as well. So what are the benefits of doing postgraduate level education. So, I mean, it gives you a more in-depth knowledge of, the physics and the evidence base. Obviously, it gives you some more advanced POCUS skills. You do get a much better supervision out of it and better mentorship. And I've certainly had a lot of opportunities for getting involved in research and publications. And teaching on courses, again, another big bonus at Teesside. One of our professors runs a course called Sono UK every year. So I've taught on it a couple times through the masters. And it just gives you a bit more credibility as a practitioner. So let's dive into the evidence a little bit then. So this was a meta-analysis by Nishijima et al. In 2012. So they looked at 22 studies, over 12,000 patients, looking at fast scanning and detecting intra-abdominal injury. So what we can see here is the specificity for fast scan, very good. Sensitivity, not so good. But it's important to note that they excluded, 5 of the studies excluded patients with hemodynamic instability. So obviously, the more unstable you are, the sensitivity of FAST is probably going to be a little bit higher. The other thing is that they were only looking at intraperitoneal fluid. They weren't looking at pleural or pericardial fluid. And they weren't looking at pneumothorax either, which is part of the EFAST. So is the jury out on fast? Well, maybe. I think with the extended fast, that I don't think traditional fast is so much a game changer anymore, given that we've got quite ready access to CT at the moment. I think it still certainly has a role in the unstable trauma patient. But I think EFAST potentially has a bigger role to play. So what extended fast is just the addition of lung ultrasound to look for pneumothorax and to look for pleural fluid, which in the context of a trauma would be evidence of a hemothorax. So if you can see here, the sensitivities and specificities are very good for ultrasound looking at pneumothorax, so in the sort of high 90s there, and the same for pleural effusions as well. So what about AAAs? So this is probably some of the best evidence that we've got out there. So this was a meta-analysis by Rubano et al. In 2013, showing that ultrasound had an excellent specificity and sensitivity for detecting AAAs. So in this case, ultrasound is a rule in and a rule out. There you go. So Bayesian thinking, Bayesian theory is probably something that's particularly relevant to emergency medicine and something that we do on a daily basis, every shift. A lot of us do it subconsciously as well. And the idea is basically based on the fact that you've got an initial belief for a pre-test probability when you see a patient, and you go ahead and do a test and you get new objective data from that, and that informs your new and improved belief for your post-test probability. So likelihood ratios, which you've probably would have all come across in papers, illustrates Bayesian thinking quite nicely, actually. So say you've got your pre-test probability on this side over here, and say we see a patient with chest pain, and you've got a 30% pre-test probability that this is an acute coronary syndrome. You then do a test, let's say a troponin, which has a likelihood ratio of 20. If you just connect the dots here, that gives you a post-test probability on this side over here. So in general, if you've got a test where your likelihood ratio is more than 10, so your positive likelihood ratio is more than 10, that's the sort of sweet spot. So anything above that is going to mean you've got a very good test. And similarly, if the negative likelihood ratio is less than 0.1, and that's your sweet spot there, and that's a sign of a good test. If it's somewhere between 5 and 10 for your positive, and between 0.5 and 0.1, then it's not particularly going to change your management, but it might help you in certain cases. Anything between that is just a shit test. So this was a systematic review by Wang et al. Looking at the usefulness of the history and physical exam and some other common, some routine investigations that we do in heart failure. So what they found was, with regards to the history and physical exam, so a lot of the symptoms that we tend to ask for in the history, so orthopnea, paroxysmal nocturnal dyspnea, shortness of breath on exertion. They actually didn't have brilliant likelihood ratios. And similarly, clinical signs like leg edema, raised JVP, again, not still, likelihood ratios of well less than 10. Interestingly, a third heart sound or a gallop rhythm had an extremely high likelihood ratio, but actually the sensitivity was very poor for that. So it was very specific if you found it, but if it wasn't there, it didn't really mean anything. What you'll also notice is the negative likelihood ratios for all of these signs are pretty poor. So again, if you have them, it might push your post-test probability in one direction, but the lack of these findings doesn't really exclude a diagnosis of heart failure. So what about some blood tests? So a BNP certainly has a useful negative likelihood ratio. So if it's negative, it might help to exclude heart failure, but certainly at levels above just using a threshold of 100, likelihood ratio was only 4.1, which again doesn't help us as much. So let's look at the chest X-ray then. If you had a chest X-ray looking like that, then fair enough. You've got your diagnosis there. So seeing interstitial edema had a very high likelihood ratio, but the lack of it, again, doesn't exclude a diagnosis of heart failure. And that goes for cardiomegaly and pleural effusion as well. It's also important to know with all these likelihood ratios, they're looking at individual factors on their own. So we're not talking about a combination of different factors. Well, let's look at long ultrasound and looking for B lines then. So this is from a systematic review in 2014 by Al-Deeb et al. And they demonstrated very high sensitivities and specificities, very high likelihood ratios for if you saw more than 3 B lines on lung ultrasound and at least 2 lung zones on both sides of the chest. So I think we can say that lung ultrasound definitely has a role to play there. So some more recent evidence. So Pavetta and all, they did a initial prospective multi-center cohort study of over 1,000 patients, and these were ED patients presenting with acute shortness of breath. They performed lung ultrasound in addition to standard care, so they used a lung ultrasound implemented approach. And they were looking at the diagnostic accuracy for lung ultrasound to differentiate acute heart failure from non-cardiogenic causes of dyspnea. What they found was in the standard care group actually had reasonable specificity for picking up heart failure. But the lung ultrasound group, so when you integrated lung ultrasound with the clinical workup, your sensitivity and specificities all shot up massively. So likelihood ratios of over 37 and 0.03, which is excellent. And interestingly, just looking at the lung ultrasound alone group, so not even taking into account the clinical workup, you still had very, very good sensitivities and specificities there. The same authors then a few years later did a RCT of over 500 patients. Again, these were ED patients presenting with acute dyspnea. And they randomized people to either lung ultrasound plus the clinical assessment, so an integrated lung ultrasound approach, versus a chest X-ray and BNP in addition to the clinical assessment. And again, they were looking for the diagnostic accuracy for heart failure. So what they found again was the integrated approach in the lung ultrasound arm. Likelihood ratios were much better, so well over 10 and less than 0.1. So again, an example of a good test compared to the chest X-ray and BNP arm, which was not as helpful. So I think the evidence in terms of point-of-care ultrasound is definitely improving, and there are a lot of better quality studies that are coming out and should hopefully sort of shape our thinking and make us realize that ultrasound has a large role to play. So I'll finish with a few cases then. So these are all cases that I've had in the last sort of 5 or 6 months. So this is a 45-year-old male, fit and well, 1 to 2 week history of feeling a bit unwell, a bit more tired, not eating, drinking as much, and came to the ED because he was feeling a bit more breathless. He was noted to be in rapid AF and triage, heart rate about 125, 130. And chest X-ray was taking a while to happen, so I thought I'd just stick the probe on. And so that's a subcostal view of the heart. And what you can see there is the heart, and then surrounded by a massive rim of a pleural fluid there, of pericardial fluid there. So that's a massive pericardial effusion. On the right here is a subcostal IVC view. And what you can see there is the IVC and the heart on this side here. And you'll notice that the IVC doesn't collapse much with inspiration, and it's dilated. So it's a fixed and dilated IVC, which is a sonographic sign for tamponade. This patient was actually reasonably stable and ended up going up to cath lab for his pericardiocentesis. But when he eventually had his chest X-ray, to be honest, there might have been a bit of mild cardiomegaly, but I'm not sure I would have picked up a pericardial effusion or even thought of it, considered it in this guy. So I think POCUS definitely helped point us in the right direction. So this is a 27-year-old female, lower abdominal pain since the night before, worsened on presentation. She had a bit of mild PV bleeding, but denied being pregnant. She had a Mirena coil in situ. She was a bit tachycardic in triage and sort of borderline hypotensive. On examination, had a very peritonitic abdomen. Pregnancy test wasn't back yet, so I thought I'd do a quick FAF exam to look for any free fluid. So this is the right upper quadrant view. So what you can see here is a sliver of free fluid around the caudal tip of the liver. Not so much in Morrison's pouch here, but it's an important point that a lot of free fluid tends to accumulate around the caudal tip of the liver first before it accumulates in Morrison's pouch. So it's an important area to interrogate. In the left upper quadrant here, you can see a rim of free fluid surrounding the spleen there and in the splenorenal recess as well. So differentials at that point, without the result of the pregnancy test was obviously this could be an ectopic pregnancy, or it could be something like a ruptured ovarian cyst. So just on the POCUS findings alone, I was able to speak to gynae, get them to come and see the patient. They'd already teed up the patient to go up to theater even before the pregnancy test came back. Incidentally, the pregnancy test was normal, but when they opened her up in theater, they found a ruptured ovarian cyst, and she had about 2.5 liters of blood in her belly. So this is a 60-year-old female with abdominal and chest pain. She was Cantonese speaking, so we had a very limited history. Presented with a one-day history of sudden onset abdo and chest pain. Appeared very uncomfortable, but had relatively stable obs. Her bloods were all fairly unremarkable. ECG was fine, troponin was normal. And this is a quick scan of her abdominal aorta. So that's your aorta in the middle there, IVC, and that's the vertebral body just behind it. And what you can see there is, I'll just play that again. That's what we call an intimal flap. So that's a sign of a aortic dissection. So this lady did quite well. She ended up having a CT scan, which showed a type B dissection, was managed conservatively, and had a good outcome. So what about this guy? So 65-year-old male with COPD, 2-day history of worsening shortness of breath, increasing inhaler use, was hypoxic pre-hospital, had a couple of nebs, which didn't make a huge amount of difference. On arrival to EDs and respiratory distress, borderline saturations on 15 liters of oxygen, and a bilateral wheeze on auscultation. So a quick scan of his lungs revealed B lines, so diffuse B lines bilaterally on both sides of the chest. So what you can see here is rib shadow there. That's the pleural line there, and again, rib shadow, pleural line. So that's the probe lying across 2 rib spaces. And these vertical echogenic lines that you can see going all the way across, those are what we call B lines. So those are indicative of an interstitial syndrome in the right context. It's usually because of alveolar or interstitial fluid. But there are other pathologies like atelectasis that can also cause B lines and interstitial pneumonias as well. But in the right context, and when they're diffuse and present in all areas of the lung, it's consistent with an interstitial alveolar syndrome. So in this case, we treated this this man for heart failure, got him started on a GTN infusion and CPAP, and very quickly turned around. So then we have a 75-year-old female, 2-day history of D&V. Today was quite lethargic and confused, hypoxic on arrival to the ED on 15 liters with reduced breath sounds on the right. So before the chest x-ray arrived, stuck the probe on, and that shows, so that's a right upper quadrant view, sort of slightly higher than a right upper quadrant view. So what you can see here is the diaphragm and the liver. So it's similar to when you do your fast view in the right upper quadrant, but I've just slid up a little bit further to look up into the lung. And what you can see there is a heavily consolidated, nasty looking lung there with a surrounding pleural effusion on that side. That entire lung was completely consolidated even when I looked up in the anterior part of the chest. Eventually, when she got her chest x-ray, it looked something like that. But I had already referred this patient to ICU before the chest x-ray, and they'd already come down and seen the patient. And right after the x-ray, we tubed her, and she was up in ICU within about 2 hours. So POCUS is a great adjunct, a great tool to help you with your clinical assessment. And it's another data point that can just help you aid with your decision making. It's pretty rapid to perform, and it facilitates earlier diagnosis and early decision making. It's radiation free and it's repeatable. It is operator dependent, but so is taking a history and examining and pretty much most other things. So I think we owe it to our patients to try and become better operators. What POCUS is not, it's not a replacement for a good history and examination. And it's definitely not a reason to delay definitive or time-sensitive treatments. It's not a magic bullet or a toy. I think particularly in the context of these days where you can get handheld devices quite easily. I think we just need to bear in mind that it still takes a decent amount of training and going through the appropriate pathways to make sure you're accredited in the right way. And most importantly, it's not a self-cleaning robot to clean your machines. So the future of ultrasound, I think it will be and already is a team sport. So I think more recently we're getting a lot more specialties like acute medicine and GP that are very interested in point of care ultrasound. So I think very soon most specialties are going to be using this, and hopefully it will become part of the general lingo. And the more people that we can get on board, and more people that understand the role of ultrasound, I think the better it will be for patient care. I mentioned handheld devices. So this is the Butterfly IQ, which is a probe that was released a few years ago, which plugs into your phone. There are many similar ones to the Butterfly IQ out there, and there are more coming out. And I think this is probably going to revolutionize the way we do things. I briefly mentioned virtual mentoring. So I think this is probably going to be the future of POCUS training. Certainly when you first start, there's going to have to be some direct supervision for when you start scanning. But after that, I think as long as you're saving your scans and regularly reviewing them with mentors, I think this will probably be the best way in which we can train. Teleguidance and artificial intelligence, I mean, this is already being used, and Butterfly certainly incorporated this into their platform, and they're doing some pretty exciting things at the moment. So thanks. Any questions at all?
Hi, Nish, that was great. Thank you. Can I ask, the images you showed us about all the different cases, were they done on the Butterfly IQ or with one of the more traditional?
No, these are all from the Mindray, so the ones that we have at MRI.
Okay, because those are some amazing images, I think, and some really great examples to illustrate how those things changed your management. A lot of other people might have just sent them home.
Yeah, definitely.
Well, I think one barrier you find is going all the way back to that chart you showed at the beginning with the dinosaurs on the tail end of innovation. is, if you, for example, said to perhaps an aged medical consultant in their 60s that you hadn't done a chest X-ray on this patient with heart failure,
Yeah.
You can get some pushback from that side of things. Would you have any advice on how to address that conversation with them?
Look, I think at the moment, I would still be doing chest X-rays on all these patients. I don't think, we're at the point yet where ultrasound is going to replace, other modes of imaging. I think, everyone speaks chest X-ray, everyone understands chest X-ray and knows how to interpret them. And, it's going to be a while before, and I don't think, point of care ultrasound, I don't think its role is to necessarily replace formal imaging. I think where, the key role for it is in terms of early diagnosis and just using it as extension to your clinical exam. I think just realizing that the limitations of our clinical exam is one thing, and if we have a tool at the bedside that can massively increase our sensitivities, then why not use it?
That's great. And can I ask one other question? Would you recommend your course at the University of Teesside?
Yeah, absolutely. The postgraduate certificate's only a year, so I'm doing the diploma at the moment. So it kind of works in a modular fashion. And the full MSc is 3 years, but the third year is just a dissertation year, so you don't do any additional modules. So that's an opportunity for, if you wanted to get a publication out of it, that's probably a good thing to do if you wanted to get involved in research and things like that. But I've definitely become a better scanner as a result of that. And I think you just, it sort of opens you up allows you to network with more, like-minded people. And also I think the mentorship that you get from it, and the supervised scanning you get through it definitely makes you a better scanner.
That's great. Thank you very much. Does anyone else have any other questions?
Hi, Nish. Hi.
Hey, Andrew, you're right.
Thanks so much for the teaching.
That's right.
You mentioned that it's growing and it's going to be quite exciting for the future. Acute medicine GPs also getting involved. Have you got any advice for myself as a GP trainee who's interested in ultrasound and used it a few times in the A&E so far, but we're going forward to courses and things?
So I think at your stage, I mean, the best thing to do is to go on an approved ultrasound course. So it doesn't necessarily matter which course you go on. I think there's a lot of overlap these days over the various ultrasound courses. So, whether you do a level 1 emergency medicine ultrasound course or the FAMOUS course or the FICE course, I think you can tailor it according to what you feel would be relevant to you as a GP. I mean, interestingly, with GP, I think there's a huge role for point of care ultrasound, and at the moment, right now, we've got about 2 GPs on our on the master's course at the moment. So I think that's definitely an avenue to explore, and I think it would definitely add a lot of value to patient care and make your referrals to secondary care just a lot better if you can use POCUS in the right way. So yeah, I think it's definitely worth going on a recognized course and go through the process of finding a mentor and having a few supervised scans and actually getting a certification in POCUS, before you're using it to make any management decisions or anything like that.
Thanks, Nish. And I've got one more slight question as well, because I can see that the benefit of POCUS in terms of that early diagnostics and detecting like the effusions and things before the other investigations. I think one sort of challenge I see is in terms of ruling out certain diagnoses, like ruling out DVT or ruling out gallstones or whatever. But so that'll be operator dependent. So what point do you feel that you can safely rule things out?
So I agree with you. I think for a lot of things in POCUS, they tend to be rule-in diagnoses, but actually from looking at the evidence for aortas, if you get a decent view, the evidence suggests that we can rule out AAAs with ultrasound. Things like pneumothoraces, pleural effusions are ultrasound is far more sensitive than a chest X-ray. So I think we need to be pragmatic about how we apply it. So that's where our Bayesian thinking comes into view. So we need to use POCUS in conjunction with our clinical exam, with our history, and essentially it's about risk management, isn't it? It's about how we manage risk and the likelihood of certain diagnoses in primary and secondary care. And ultimately our decisions, we make decisions about discharging patients home on the basis of chest X-rays and blood tests all the time, or simply just our clinical exam and history. So we're already doing this, and we're using tests that are probably less sensitive in some ways, but we use our clinical judgment at the end of the day. So I think POCUS needs to be integrated into that in the same way. And we're not using POCUS in isolation. We're using it as part of as an adjunct to our clinical examination. I think the benefit that we have as point of care practitioners over, say, a sonographer or a radiologist, is that we have all the patient information. So we've seen the patient, we've examined the patient. So actually, we're going to gain a lot more out of doing the exam, the POCUS, because we already have a much better idea of our pretest probability. And so we can make a better judgment on the basis of our findings, or we could decide to refute our findings because it just doesn't fit in with the clinical scenario.
Thanks so much, Nish.
That's right. Any other questions?